guys, and welcome to episode 263 of the OCDstories.com podcast. Now, firstly, thank you as always for listening. I deeply appreciate it, and I hope the episode helps you. And if you get time, please leave a review on iTunes or wherever you listen to this podcast, as it helps me reach more people. So, in this episode, I interview Stephen Phillipson. Many of you would have heard my interviews with him before. So I'm happy to get him back on to talk specifically about somatic OCD, sometimes called sensorimotor OCD. And I wanted to cover this theme or subtype of OCD because it doesn't get talked about as much, and it is slightly different to the others, but still very much OCD. So I wanted to shed some light on it, and if you are affected by this, I hope it helps you in some way. So, in it I asked Steve, what is somatic OCD? What are neutral obsessions? We talk about the obsessions and compulsions of this theme, how depersonalisation or derealisation may be a subset of this theme in his opinion, how certain personality styles may play into this theme, how often he sees this theme in his practice. He gives plenty of case examples to illustrate the treatment for this theme. We talk about the focus of therapy for somatic OCD, examples of exposure and response prevention therapy for this theme, why Steve gets his patients to record each therapy session, what he wishes he knew when he started his journey in therapy, and Steve's biggest life influences, and much, much more. And this podcast is made possible and sponsored by NoCD. To find out more about NoCD and their therapy plans, and if they currently take your insurance, click the link in the episode description or head over to go.treatmyocd.com/theOCDstories. So thanks to NoCD for supporting the show and to you guys for listening. And without further ado, here is Dr. Stephen Phillipson. On today's show, I have Dr. Stephen Phillipson. Stephen is a licensed clinical psychologist who specializes in cognitive behavioral therapy for OCD. Stephen is a clinical director at the Center for Cognitive Behavioral Psychotherapy in New York. Welcome back to the show, Steve.
Always a pleasure. You know that, Stu.
Yeah, it's good to have you here.
And
yeah, thank you. So today we're going to talk about somatic OCD, or sometimes called sensorimotor OCD. So I guess, but from now on, I'll just refer to it as somatic OCD for simplicity. So let's start with, what is somatic OCD?
The original term that I was introduced to this topic was a number of years ago. It was referred to as neutral obsessions. Interestingly, and I'm glad that it's now sort of transitioned more toward a somatic OCD. I think they refer to it as neutral obsessions because, most of OCD has a very clear-cut threatening component to it. If I touch the doorknob, I'll die of AIDS. If I don't check my stove 100 times, the house will burn up. If I have a thought of injuring my child, I could, be at risk to performing such a negative task. So with neutral obsessions, the theme, the top three themes of neutral obsessions, or somatic OCD, and I definitely will try to use that term, are an awareness or perceived over-awareness of one's blinking, one's breathing, and one's swallowing. Those were sort of the big three. It's the idea that, like until right now, I have not been aware of one swallow, one breath, or one blink. But as we go forward in our conversation,
I have. Sorry, just to cut in there. When the moment you said swallowing, I became hyper aware of my swallowing. It felt really awkward, and for about 20 seconds after, all I could think about was my swallowing. So it just shows you like where your attention goes, and you can't let it go, sort of thing.
Right, and the idea is, like, if my brain alerts me to some blinks or some swallows or some breaths, I just became aware of a swallow. I can, without having OCD, be very dismissive of it, thank my brain for the information, and sort of move on. But for someone with OCD, obviously there's a pairing of the alarm signal, the distress signal.
Yeah.
And that's what ties in a sense of problematic awareness to these ideas. So, but it turns out with somatic OCD that these top three are not really the end all of the expression of this form of the condition. Another common theme is if a person gets a song stuck in their head, the idea that we are waiting for this independent system awareness, independent system production of this music to go away, as if the presence and awareness of the song is problematic, and that's really the heart of what makes this theme so pronounced. So in the beginning, when it was referred to as neutral obsessions, there was, I think, a misunderstanding, the idea that there's no threat, as I had said, but actually the threat to these awarenesses is the idea that in being aware of it, one becomes distracted. And there's a sense of almost like a rule-bound thinking that, we shouldn't be aware of our blinking, breathing, swallowing. We shouldn't have a song stuck in our head. We shouldn't be aware of our own heartbeat. We shouldn't be aware of feeling disoriented. So I think like depersonalisation disorder or derealisation are also sort of subsets of this somatic theme.
Okay.
And the issue is that the feared awareness is that it will take away from our optimal performance. So being distracted by this excessive awareness or inappropriate awareness, that distraction actually is the threat. And so therefore it really fits into the classic OCD model that there is a challenge awareness and the person will seek some type of undoing. And in this response, the undoing is the desperation to not be aware of these signals. Another form of this, I had a patient who had floaters, just sort of these little stars or these little dots that would float around if she looked at a plane surface. And once again, the awareness of these floaters became very distressing to her, that once again, she shouldn't be aware of them. And what's interesting, Stu, with this specific theme of OCD, we can make two pretty strong predictions in terms of personality styles that tend to go along with this theme within OCD. So the perfectionist has a rule about these awarenesses should not exist. And so the idea that the brain is sending an awareness when it shouldn't be, the violation of that rule or that sense of need for excessive control, it marries up a personality style with this spike theme and this conditions presentation. And the second most common personality style that accompanies the spike theme is people who have an over-attachment to a sense of their image, their presentation, how others see them. And so with this form of OCD, where there is an over-attachment to image, the idea is that if I place expectations on my ability to access my interpersonal skills or my cognitive functioning, and this awareness becomes a distraction and a diminished faculty, a diminished effectiveness in these areas, a person can become very distressed at their loss of access to what they perceive to be these talents in terms of their ability to be interpersonally skilled or their ability to communicate in a superior way, or their ability to kind of focus and be able to analyze thoughts in a way that they feel competent about. So that's sort of a very interesting kind of marriage. So the themes of this type of OCD, once again, formulate around the idea that the awareness in and of itself is the problem. And I wrote an article recently, or I'm in the midst of finishing an article, on the concept of how a person's sense of resentment can in and of itself act as sort of an undoing response or a ritual. And within this spike theme, there tends to be a tremendous amount of resentment. Why is my brain sending me this awareness? It shouldn't be. When will this end? When will I get control back? When will this torment, leave me? And so in and of itself, the rejection of the brain sending these signals produces sort of that completed cycle in terms of a ritual. And that can often very much sustain the brain's hyper-awareness to these sort of somatic experiences.
Yeah. Yeah, thank you for that. And you mentioned a compulsion there, but what are sort of the common compulsions that one would be doing if they're hyper-focused on sensations?
I think a common compulsion is just the rejection of the brain's prompts and attempts to turn one's thoughts to other topics, but not with an acceptance that allows for the brain to be willing to send these signals, but more with the idea that, well, if I'm going to now turn my attention to this other topic, take sailing, for instance, that it shouldn't be polluted, it shouldn't be disrupted by the brain's tendency to reset back on these excessive awarenesses.
Okay, so have you got more to say on that initially before I jump into some questions?
I think that about covers it. Interestingly, in terms of the potential treatment for this condition, it really involves a tremendous amount of permission giving to really understand, once again, the duplicity between our autonomous choice-making capacity as the gatekeeper and the brain and the machine's ability to generate awarenesses, generate thoughts, and send them to our awareness completely out of control. And so it's critical that for this subtype of OCD, that patients really develop a skill at relinquishing control and giving their brain permission to act in this very independent way.
Yeah. So letting go of, so I'm just trying to get my head around it. So letting go of control and just being okay effectively with what the brain's doing or trying to tell us.
Exactly.
Okay. Yeah, I guess my next question is, I've asked you this before when we've done sort of theme-specific episodes, but in your experience and in your own practice, how often do you see this theme among your patients?
Yeah, this is definitely not within the top 20 OCD themes. It's more within the top 50. Generally, there will be one or two patients on my caseload who will experience one of these forms of excessive awareness. It's funny, one of my patients from England who's done tremendously, his somatic theme was an awareness of his own nose. And it's funny because when I would speak to him, I would become aware of my own Jewish nose, which becomes pronounced when he would talk about his nose. Like, oh, there's my nose. And once again, like, I'll bet you, Stu, you haven't seen your own nose today until now.
Yeah, I'm trying to look at it. Yeah, I can see it now. If I cross
So
my
for
eyes.
him, once again, his somatic expression, if we could even call it that, because it's the idea that the awareness in and of itself shouldn't be on my mental radar. And so it was a really, so we had a lot of fun creating purposeful nose awarenesses. But yeah, it is definitely more in the top 50 of OCD themes and definitely not in the top 20. So a lot of people with this type of OCD are misdiagnosed or have a very difficult time finding this as being a subset of OCD, because it really is one of those themes that falls pretty much on the periphery of people's awareness and discussion of OCD. So I'm shocked that after all these, you're probably on episode 250, that this is the first time we're discussing it, and I'm very privileged that you asked me to talk about it.
No, thank you. Well, this will be probably close to the mid 260s because I'm just over 260 now. Um, so yeah, that in itself says something, right? That it's taken me that many episodes to cover it.
Yeah,
Because even when I used to publish written stories on the on the website, I would get from memory there was a few that talked about this theme, but normally it just wasn't mentioned. And I can only think it's not because it's not necessarily out there. I mean, maybe it's out there less than other themes, but I'm sure people, as you say, get misdiagnosed, underdiagnosed for it. It's they themselves don't necessarily, because the thoughts aren't as troubling, maybe there's less urgency to seek treatment until it gets really distracting to the point that you just can't sort of tolerate it.
yeah,
Um,
yeah. And if you
yeah.
think about now with the expanding knowledge of the variety of OCD themes, this still remains a very, I would say, not well discussed, not popular theme within OCD, and yet
Mm.
I've seen it throughout my career.
Yeah, I agree. What came to me there, like from a marketing point of view, it doesn't have that PR, it doesn't have that angle, harm or sexual violent intrusive thoughts has that shock factor to it, contamination OCD has the clear visible compulsions, and that's the angle that people will talk
Yeah,
about it. This is kind of can go under recognized.
yeah. It's interesting because the compulsion here, as I said, is the sense of injustice, the sense of intrusiveness, the sense of lack of control, and then the resentment around the brain doing something so misbehaved, so uncommon, so unnecessary, that in and of itself, the idea of seeing the brain betraying our ability to be in control, that really becomes the hallmark of the compulsive aspect of the condition. So, it's such an ambiguous form of a compulsion. The idea that the expectation that these awarenesses shouldn't be there, as really the forefront of the compulsive aspect of
Yeah,
it.
absolutely. And does it ever get to a point for some of your patients in your experience where there's almost this sense of, or this fear of, it's never going to go away, almost a fear of kind of, I hate to use the term, but going crazy, that kind of, what happens if I can never get it out of my head sort of thing?
Yeah,
Um,
it's interesting that of all of the themes of OCD, I haven't mentioned this until now. I would say at this point the number one spike, the number one intrusive thought of all of my OCD patients comes back to the idea of the never-ending nature of the brain's malfunctioning. The idea that I will forever be trapped in this cycle, and that goes across all spike
yeah.
themes. Actually, the gay spike, the HOCD, and the POCD are very much up there in terms of like, oh my God, I need this to stop. But definitely within the somatic OCD, it is a very, very common subset of the resentment, the fear of, and like you said, I'm going to go crazy, which I'm happy to say and act very naughty and give some reassurance. People never go crazy from OCD. You can rewind that 1,000 times. People never, ever have a psychotic break or go crazy because of OCD. But it certainly feels like a person's edging toward that mental loss of control, which actually is the case because we don't have control over our mental activity. But it never really slips off into an area of losing one's mind or losing one's sense of reality.
Mhm. Yeah. Yeah, there's the part of me that just wants to reverse that reassurance and just say something. But yeah, uncertain, but I won't.
Yeah,
Um,
yeah. I think there is a part of therapy occasionally that can just be information
yeah,
dissemination, and
yeah,
I don't mind, especially in the early meetings with patients, just to kind of make sure that they are up with the actual scientific information
yeah,
about the condition. Obviously, it produces no long-term benefit, but it certainly can give someone a sense of like, okay, I don't really, my brain might tell me I'm going to go
Mm.
crazy, but, in the world of scientific evidence, there is no evidence to support the idea that insanity is a byproduct, of OCD's systems.
Yeah. No, I agree. And yeah, the people need the information. So that's not reassurance. Well, it may be reassurance giving, but it's an acceptable, a human amount of reassurance. It's what any human needs and deserves. It's just OCD when you've told them already, they
Yeah.
pretend they forgot and you tell them another 5 times.
Yeah. Well, it's
That's
not
a
that they pretend
disorder.
they forgot. It's that
Yeah.
they feel like
Yeah.
there's some exceptions to the rule. Like,
Yes.
how could Steve tell me I'm not going to go crazy? He's never met me. I feel
Yeah.
so close to insanity. So the brain is always able to override any reassurance and then reset on the threat and the risk more than any reassurance ever has any longevity. Because you have to remember, it's the malfunctioning amygdala that drives all of OCD's themes. It's not really the themes in and of themselves. So as I mentioned in my choice article, talking actually about the themes is like talking to the barking dog. It's not really going to have any impact on reformatting the amygdala.
Yeah, true. Yeah, and when, like you said, when the brain's in that place, it will find a million different variations of what if to get that reassurance of what as if I didn't hear him right, I heard it wrong, or I didn't ask the right question, or whatever. Okay, so the next question for you then, in your experience, how often with someone with this theme, do they also have the normal kind of ego dystonic type themes of like, I'm going to hurt someone, what happens if I'm going to catch HIV from a doorknob, or do they go hand in hand, or is it usually just somatic OCD by
Yeah,
itself?
it's interesting. Certain OCD themes tend to cluster. People with HOCD tend to cluster with people who have ROCD, people with relationship substantiation, and also pedophile OCD. But within the somatic subtype, it tends to more cluster around other types of inappropriate awarenesses. So my person with the nose awareness also has breathing awareness and also has DPD, depersonalization disorder. So that's the awareness of like, I don't feel right. I don't feel like I'm in my own body. I don't feel like I'm in my own world. And this awareness of being separate from, or the awareness of things not feeling like, everything is sort of normal, as it were. Like right now, I feel like I'm in my own body. I feel like I'm engaged in my own process. With DPD, it's like the conscious awareness is lifted out of your own body and you're now looking at you, feeling very disoriented, feeling very unnatural.
Yeah.
And so once again, in the world of the somatic spike, the awareness of things being off and unpleasant and not under control really is the catalyst, the trigger for the need to kind of regain control and regain equilibrium.
Yeah, makes a lot of sense. Okay, so where am I at with my questions? Yeah, okay, I think we've set it up nicely. Yeah, so we can talk about treatment now, but my kind of kickoff question was, well, A, case examples, but B, what's the focus of ERP for this theme? Because we're not necessarily approaching a core fear. So what are we kind of targeting with ERP?
Well, actually, the core fear, now that you mention it, is the idea that I'm going to be prompted and distracted about topics that shouldn't exist on my radar in the first place. So one aspect of treatment involves people setting an alarm to have the alarm go off maybe 10, 20 times a day to just prompt them to be reminded of or made aware of their breathing, blinking, swallowing, heartbeat, nose presence. Oh, there it is again. You name it. So in that regard, a person having the alarm go off, giving them the opportunity when the alarm goes off to not only become aware of these inappropriate awarenesses, but also then to give permission and license for that awareness to coexist. So a lot of times, with this theme, it's really important that a person develop a willingness to function at a level below what they expect or are aware that they're capable of. So once again, I mentioned in the choice article, the idea of kind of living on the crumbs. And so with this type of OCD, it's very important that people make room for a lack of control in accessing their mental faculties. So the perfectionist has to give up their demand to be their absolute best self, and the image-based person has to give up their demand to being in control of offering to their audience, offering to other people their absolute interpersonal competence. So that's a huge component of it also, not only the idea of voluntary triggering and provoking of these awarenesses, but also the tolerance to our functioning being diminished and making room for that awareness. Mm. So one of my favorite sticking points for these somatic symptoms, and this is a very common kind of question that comes up. So let's say my spike theme, my intrusive thought theme is swallowing, right? And so my brain says, oh, if you swallow now, that's giving in. Mm. But then my brain says, if you don't swallow now, that's avoiding. What do you do? And so in this regard, and I mentioned before in a prior podcast with you, once again, the two-tail spike, right? Mm, yeah. So if you swallow now, you're giving in. If you avoid swallowing, you are avoiding. And the answer is that you just swallow at any time you choose to, and in that moment you accept that this was the wrong swallow, this was the wrong blink, in terms of a heartbeat or things that are more independent rather than things that we can control, like swallowing, like breathing, like blinking. It's a little bit easier to just kind of, rather than, turning it over to this idea of having a choice, to just kind of letting these awarenesses kind of be there, accepting that our brain can turn our awareness to our heartbeat, to a floater. These are things that we can't make choices about, but the idea that being aware is in and of itself the problem.
Yeah, it makes a lot of sense. So we're like the alarm idea. We're kind of reminding ourselves that to be aware of let's stick with swallowing. To be aware of our swallowing. Let's say in session, maybe that's an easy place to start. You're in session with someone. I'm hyper focused on my swallowing. This sensation I feel I have to swallow whenever, whatever it is. How are you doing exposure with me in session to kind of get me to tolerate that?
So I would bring up, what you're already aware of, is swallowing. Mm-hmm. And I would say, okay, so whenever you swallow next, let's accept that that's the wrong swallow, that's the swallow that means that you just screwed up. And when we embrace and we make room for the awareness that all swallows are the wrong swallows, the brain kind of starts to let go of needing to monitor getting it right. Mm-hmm. Once again, within the two personality styles, the perfectionist wants to make the swallow, the blink, the breath, they want it to be the correct breath. And so abandoning that relationship with getting it right, or the idea that right or wrong even exists, can be a very powerful component within the treatment process.
Yeah. Okay. And then you'd set the homework of maybe the alarm on the phone to kind of keep bringing their attention back.
That's right.
Yeah. So that is the exposure there of.
Yeah. Another thing we might do is we might have a conversation, let's say, about one of your hobbies. Yeah. And while you're engaging in this conversation, I would have you just raise your finger every time your brain prompts you about one of these distracting themes. And in that regard, you're allowing yourself to be engaged in this natural conversation about this topic, non-OCD related, but also making room for and acknowledging the brain's prompt about your breathing or swallowing, and having that be a moment of acceptance and permission giving.
Absolutely. And I guess they're learning also that, hey, I'm still living my life even with this thing present. It doesn't have to
Exactly,
stop
that I
there.
can engage in a meaningful and productive conversation about, whatever your hobby might be,
Yeah.
and still go on with that conversation while making room for the idea that these awarenesses, these distractions can be part of my backdrop.
Yeah. Nice. Okay, great. Just looking at my questions. Yeah, I guess, are there any other case examples you want to use to illustrate, even like maybe the British guy with the nose focus, how you kind of worked with him?
We did the alarm, and he was a very conscientious patient, and I mean we really had a good time. Also, bringing humor, into the therapeutic process, and I think that was really also very instrumental because he was a very kind of serious person, but when we started making fun of his brain's awarenesses and we had some good laughs, it really helped to diffuse the idea that, I shouldn't be aware of my nose. That, why, like for him, there was a lot of expectations, a lot of issues of control. And so we worked a lot with, giving the gatekeeper, giving the brain permission to come into the moment, to create a distraction, and to really see that, that independent system, that the brain voice is something that when you really give it license to act in a very independent way, rather than looking at it like, many people initially would say, why am I focusing on my nose? Why am I so aware of my breathing? As if the person is making a mistake through that awareness of their breathing or the awareness of their nose, as if there's something about them that's defective, that they keep coming back to these awarenesses. And so even that portion of psych ed, that our brain acts in an independent way, brings our awareness to things that we have no control over, and yet we can give it that permission to function in that way, or even malfunction in that way, while we move forward and make room for whatever minimal amount of brain information or minimal amount of focus, that we're left with.
Yeah, that makes it.
One patient I had, it was an interesting combination of classic OCD with somatic awareness. It was very interesting. He had a thought that being aware of his breathing, but the very nature of the awareness would then change the cadence of his breathing, which makes sense. And in changing the cadence of his breathing, the pacing of his breathing, that would give him brain damage. And so he had this classic threatening OCD spike along with the not so classic somatic awareness, and the two teamed up. So his awareness would mean that changing his breath pace would then give him brain damage. So it kind of circled back to more of the traditional OCD within the classic somatic OCD.
Kind of like a health anxiety fear. So yeah.
Exactly, that's right, yes.
Okay, and you mentioned earlier about some people get like the song stuck in their head and not being able to let it go.
Yeah.
What are some ways in therapy you'd work with that?
Once again, not so creative, but within the very potent means of OCD ERP, the reminders on the phone, playing the song purposefully, on your phone. You can kind of play the song voluntarily. One person I worked with, and he actually wrote an article on my website in one of the graduate success stories. The theme to the Pink Panther would play in his head, and interestingly, it was only during times that we labeled as what we called the Kodak moment, and in this country, a Kodak moment meant a very special time that you'd want to take a picture of to capture the magical nature of it. So if he would be on his very high-end golf course, starting out on an 18-hole course, his brain would start playing the Pink Panther song. Are you familiar with that, by the way?
Yeah, I am, yeah. It's stuck in my head right now.
Okay, terrific. You're going to be suing me after this conversation. I'm making havoc for you. So his brain would start playing dun, 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 da-da,
Dun,
da-da,
dun,
da-da,
dun,
da-da,
dun,
da-da.
dun.
So now everyone can have that song
Yeah.
stuck in their head. But it would only play it in these magical Kodak moments, and he processed the brain's independent playing of that song as raining on his parade. The idea that, he's created his magical, beautiful life, and in these very special moments, like when he would see his house, for instance, his brain would start playing the song. So rather than being able to observe parts of his life that were very special, that were very unique, his brain would rain on that by creating this distraction. And if you think about the way the brain works, it makes perfect sense. His rejection of the Pink Panther song during these special moments in and of itself created a fragility that the brain then became more and more focused on during these magical moments. So he literally conditioned his brain to play that song as he became aware of things in his life that were very special and unique and sort of privileged.
Yeah. Okay. And I don't know, would there be any use to like singing the song, bringing it on purposely, like
Sure,
loud
absolutely.
and
Yeah, whether you play it and listen to it or whether you bring it on yourself, definitely to show the brain the irrelevance of the presence of the song is, definitely in keeping with the ERP spirit.
Okay, cool. Yeah, I guess so. This theme, ERP, is it sort of as effective for this theme as other themes?
It is, but it really benefits from more of a combination in working with the person's style to abandon their need for control, or the person's style to abandon their need to be in possession of their kind of interpersonal faculties and optimize them. So in this regard, it's one of the fewer conditions of OCD where you really want to combine a personality reformatting along with the classic ERP work.
So it's as effective, but a bit more tailored to the individual's personality and character. Okay, yeah, makes sense. Okay, so I got a couple of other sort of more random questions not to do with this theme. So before I change direction, is there anything else you wanted to say on this theme?
Yeah, I was actually on this theme. No, I was going to be a little bit of a naughty person and bring up something that I don't think I'd mentioned before.
Yeah.
And so here we are burying it in the middle of this somatic podcast. So you can bring up your tangential topics, but I want to bring up a tangential topic that has been part of my career now for probably 20 years. And it's a very, I think, unusual thing that I do with all of my patients. And I'm going to bring it up because I really want this to be expanded. And what I do, Stu, is I'm not even sure that you are aware of this. I have every one of my patients record every one of my appointments. And I then have them, as part of their homework, listen to our meetings in between our weekly appointments. And I can tell you that it more than doubles the therapeutic impact, because when patients are able to review what has taken place in this session, they're really able to kind of process and synthesize so much more material and so much more depth as to what they're doing, what I'm saying. And so I just really want to make a call to all patients, all clinicians, please record every one of your meetings. Patient buys their time. They pay for that time. And in my mind, for them to be able to take home what they've purchased is a very, very meaningful and I think very beneficial part of the therapeutic process. What's interesting is some of my patients will listen to it once and then delete it. And some of my patients actually create these files that they save for many, many years. And they'll label the appointment in terms of some of the main topics that were talked about, and they will go back during certain times of challenges and replay a meeting that might have taken place 6 months ago or 4 months ago, because we touched on a topic that they may be revisiting at that time. And so I just can't, suggest enough how important this is and how beneficial it has been to many, many of my patients.
I agree. I was reading Irvin Yalom recently, and he talks about if any of his clients have a long drive, he gets them to record the session and listen to it on the journey in, so that when they come to, and obviously he wasn't a CBT therapist, right? So it was more free flowing. So often people would get distracted each week and bring up something completely different. So he by getting them to record it and listen back, they would pick up almost where they left off. So he found it was way more fruitful than, yeah. Okay, so my detour now. So what's the one thing you wish you'd known when you began your career?
How important the relationship is to most of my patients. When I started my career, I thought, I'm just this person they see for 45 minutes once a week. I must not be that important. And as years have gone by, I learned that the therapeutic relationship is probably one of the most important relationships that most of my patients have. And it really, has made my degree of conscientiousness and appreciation for what I say, what I share, and to appreciate, the importance of the bond as being such an instrument of change. So I wish I had known. I wish someone had told me, when I started out, that I'm not just this mechanic that they visit for 45 minutes once a week, but I become an incredibly integral part of their world. And, many patients will talk about how they'll think about the things that we share. They'll review our sessions and, just how vital that relationship, is for many of my patients.
Yeah, I agree. It's a special relationship. It's one I treasure with my own clients, and equally with my own therapist. It's one that's meaningful and important to my life. Okay, so next question is, who are the 3 people who have been the most influential to you in your life, apart from me?
In my life or my career?
Whatever one is more meaningful to you, answer it that way. Let's do both.
Oh, you're so selfish, though. Yeah. In my life, I would say number 1 was my mother. My dad died when I was 2, and so I was raised completely by my mother. And she really showed me, that the single woman could raise 3 boys, go on in her career and her profession and become extremely successful, and yet provide a very intact family home. A very, very, I never grew up wanting basically anything. Turned out I was pretty poor, but I didn't even know because I was from a single parent home. But, there was no one around me going on lavish vacations because I lived in a pretty modest background. But my mom did a great job of creating a sense of being very intact and growing up in a very kind of fulfilling life process. That'd be number 1. Number 2, I would say, well, you really get me with these surprise questions. One of my mentors at Johns Hopkins, his name was John Cataldo. When I was at Johns Hopkins, it was a very intense research facility, and they took their research really seriously. And I was more oriented on the clinical side rather than creating publishable articles from the patients. I looked at it more as an opportunity to do good work with patients. And this mentor, John Cataldo, he did a great job for me of balancing the application of what we were doing at Johns Hopkins between being a really loving clinician and also being a good researcher. He said to me once, he said, "Steve, great psychologists don't show up on TV." And he saw perhaps a little bit of ambition in me at that time in 1984. And, he really taught me that the most important thing I can do is refine my skills as a clinician. And that doesn't mean becoming popular or famous. And so I really appreciated, that guidance from him. I would have a hard time coming up with that many more people.
What about, oh, sorry, go on.
When I was in 7th grade, I'm dyslexic. I'm not sure if I've mentioned that. I'm severely learning disabled. I literally spell on year 3 level, and my reading is tremendously handicapped. But when I was in 7th grade, I first went to a Catholic school. I'd always been in a public school where teachers didn't really attend to specific students. But in 7th grade, it was such a teeny little Catholic school. The nuns saw in me the potential that I wasn't used to working toward achieving. And they really pushed me to, dig in to what I was capable of, because I was used to kind of just getting by, getting a C grade. And the nuns were like, no, you could do much better than that. So they asked my mom permission if they could kind of give me some tough love, because they wanted me to be more disciplined. And my mom said, sure, go ahead. So those nuns in Catholic school really turned my life toward a path of striving for excellence when I thought I was just capable of mediocrity. So in that regard, it really had 2 impacts, both professionally and personally. But like I said, to come up with 6 it would take.
Yeah, that's fine. Well, that's a powerful message to give a young boy or girl, to raise the bar for them and tell them they can be more. It's an empowering message. And so let me reframe the last one then, the clinical one was, you may have never met them, but who are like free therapists or psychologists, or that you've read or have just inspired you in one way or another through
Sure, yeah, that's much easier.
Okay.
So Albert Ellis,
yeah,
I never met him face to face, although I attended quite a number of his lectures. Albert Ellis started out as a Freudian. He didn't really, as an intelligent person, see a lot of respect in the therapy that he'd been trained in. And he went over to focusing on the way people think, rather than delving into very early childhood memories and dream analysis. And so he really had a wonderful influence in terms of my looking at a therapeutic process of being a focus on dissecting human thought. So when I work with depression, when I work with personality challenges, I really focus a great deal on that aspect of the human psychology. And it even shaped my own philosophy. I'm a complete relativist, so I don't believe in any truths or facts or right or wrongs. Everything to me is based on my own perceptions. And so my entire life philosophy is really a derivative of the work that Albert Ellis published in that regard.
Yeah. And that's REBT, right? He did.
IREBT, right? Institute. Rational Emotive Behavior Therapy. Yeah. So REBT, yes, Rational Emotive Behavior Therapy. That's correct.
Nice. 2 more then. Who else?
Oh,
2 more.
Let's see.
Not bad.
I mean, obviously, B.F. Skinner and what's his name? That Russian with the dogs, or Johns Hopkins, right? Pavlov. Thank you. B.F. Skinner. He put science into psychology. Before then, it was just philosophy from Freud and Freud's followers. B.F. Skinner decided that human behavior could be assessed with numbers and statistics and probability. And it's interesting, very few people know this, but psychology is the science that invented statistics in terms of probability. So B.F. Skinner, John Watson, Pavlov, they turned psychology into something that was quantitative rather than just qualitative, meaning that numbers could help explain human behavior and also assess the impact of treatment to say, yes, this treatment is effective, that treatment's not effective. So definitely B.F. Skinner would have to fall there.
Yeah.
And one of my mentors in one of my 2 internships, Steve Fishman, one day I was a new intern and feeling positive about my life. And I don't remember what I said, but Steve Fishman said to me, he says, "Phillipson, you are the lowest form of life on this planet as an intern. Interns are the slime that grows at the bottom of whale poop at the bottom of the ocean. That's how low you are." And I loved him for saying that to me. It really kind of centered my modesty to say, yeah, I'm an intern. I'm just beginning my career. I'm a nobody. I'm a nothing. And he reminded me of that on a regular basis. And I definitely appreciated that message.
Nice. Okay, cool. Thank you for that. Where's my question? So yeah, I guess lastly then, just anything else you wish you could have shared today?
No, I think we got it all in. It just, I'm so happy to be talking about that somatic form of OCD.
Yeah.
And really bringing light to something that very few people are aware of as even being a diagnosis under that umbrella. So no, it's a real privilege and very happy to have this opportunity to shed some light on this obscure topic.
I agree. And I think any kind of therapists who are new to treating OCD, I think hopefully this has been useful, because it may be, a few weeks, months before they get a client like this. So hopefully it will help when they do. So yeah, thank you so much for sharing, and as always, for coming on.
You're welcome. It's always a pleasure, Stu. I always enjoy our chemistry.
So there you have it. Thank you so much to Steve for his time, and to you guys for listening. If you wanted to check out the other episodes I've done with Steve, you can of course search in whatever podcast app you listen to this, or Spotify or YouTube, and you can check out those. I'll put the links in the show notes to this episode as well. And don't forget, today's episode is sponsored by NoCD. To find out more about NoCD and their therapy plans, head to go.treatmyocd.com/the OCD stories. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.